Hi, my name is Alyssa, and this is Medisin, where learning is always in style. Today, we will be discussing the complications of myocardial infarctions. By the end of this video, you will be able to explain the pathogenesis of myocardial infarctions, outline the myocardial changes following MIs, describe the possible complications of MIs, and identify the risk factors for MIs. Before we start, make sure to like, comment, and subscribe. Also, follow our Instagram @MedisinStyle for more content on life as a med student and study review. Okay, let's get started. One of the scariest things that can happen to anyone is a heart attack. And in medicine, we call those myocardial infarctions. Myocardial infarctions are caused by blockages to the coronary arteries, which supply the heart muscle, or myocardium. During a myocardial infarction, or MI, the myocardium actually dies. The portion of the myocardium that dies then stops pumping. Therefore, if a large enough region of the myocardium dies, the entire pumping mechanism of the heart can stop, which may lead to a lack of blood flow to the organs, and the person can even die. However, MIs do not necessarily lead to death. In people who survive MIs, the infarcted portion of their myocardium undergoes post-MI tissue modifications. First, let's start with a healthy myocardium just before an MI. Here's a picture. On day 1 following the MI, the myocardium undergoes coagulative necrosis. During coagulative necrosis, the infarct to the myocardium leads to the denaturing of structural proteins, like lysosomal enzymes. Without these lysozymes present, the overall architecture of the myocardium does not break down. It is preserved in a, quote, coagulated morphology. This is like taking the furniture, plumbing, and electricity out of a house, but leaving the framework. Coagulative necrosis is one of the few necrosis types that has the potential for cellular regeneration. Now, from days 1 to 3, post-MI, there is maximum neutrophilic infiltration into the necrosed myocardium, which means that the area begins to have inflammation. Between days 3 and 7 post-MI, macrophages infiltrate the area. Now, this is an especially dangerous period for patients. The myocardial wall has become very friable from the inflammation, and a scar has not yet formed to strengthen its integrity, which means patients are at a high risk for ventricular wall rupture and cardiac tamponade 1 week after their heart attack. After this period, and until about 8 weeks post-MI, the infarcted area begins to develop granulation tissue with the help of fibroblasts. These cells help heal the injury caused during the MI. Therefore, the myocardium has a mature scar with fibrosis over the area of infarct 8 weeks after the MI. Now, the fibrosis strengthens the damaged heart wall, but fibrotic tissue of all kinds loses its functional integrity. Just think of a big cut or burn you ever got on your arm or leg. Once the scar forms over the damaged area, the skin of the scarred area may lose sensation, and hair may never actually grow over the skin again. The scar tissue has lost the original function of the healthy skin tissue. The same idea applies to the heart. The myocardium that has undergone fibrosis after the MI loses the contractile function of the healthy myocardium. Therefore, the scarred part of the heart may not actually pump well again. Now that we understand the timeline of post-MI healing, as well as the nature of fibrotic tissue, let's try to understand the possible complications that may happen in the days, weeks, and months following myocardial infarctions. Within the first 24 hours post-MI, the person is at risk for a cardiac arrhythmia, such as ventricular fibrillation. Arrhythmias are actually the leading cause of death during this time frame, and can often cause people to die before ever reaching the hospital. Between days 1 and 3 post-MI, the possible complication is a post-infarction FIBRINOUS pericarditis. This is inflammation of the pericardium, which is the sac surrounding the heart. On physical exam, we would hear a pericardial friction rub. Between days 2 and 7 post-MI, the patient is at risk for papillary rupture. The papillary muscles control the opening and closing of the heart valves. This can lead to severe mitral regurgitation in the setting of papillary rupture. Between days 3 and 5 post-MI, the patient is at risk for interventricular septal rupture. This is when the wall between the two ventricles breaks. Notice how this rupture corresponds to the time when macrophages infiltrate the healing myocardium. Interventricular septal ruptures are actually mediated by macrophage degradation. This leads to a ventricular septal defect that increases the oxygen and saturation pressure of the right ventricle until it ultimately bursts. Now, between days 3 and 14 post-MI, the patient is at risk for a ventricular pseudo-aneurysm formation. This is when the outer ventricular wall ruptures, but the blood is contained by the adherent pericardium or scar tissue. From the outside, this looks like a ballooning of the tissue, hence the name pseudo-aneurysm. This increases the risk of arrhythmia, as well as embolus formation from a heart wall thrombus. The risk of a ventricular pseudo-aneurysm also corresponds to the time frame for risk of ventricular free wall rupture. This is when an outer wall of the ventricle ruptures at the site of infarct healing, leading to bleeding into the pericardial space. The blood builds in the pericardial space and places pressure on the pumping heart. This is a cardiac tamponade, and cardiac tamponades can lead to sudden death. A cardiac tamponade presents with Beck's triad: hypotension, venous distension, and muffled heart sounds. Watch out for these 3 cardinal signs. From 2 weeks to several months post-MI, the patient is at risk for a true ventricular aneurysm. This is when the entire heart wall weakens and balloons outwards, which may disrupt contractions. This time period may also correspond with Dressler syndrome, which is an autoimmune reaction that may lead to fibrinous pericarditis. Any number of these complications can lead to left ventricular failure and subsequent pulmonary edema. Therefore, MIs are not just dangerous because they can lead to death, but because they can lead to lots of other dangerous complications. This timeline corresponds the tissue modifications following an MI with the complication risks following an MI. It helps to coordinate the physiology with the clinical presentation as you study. Take this screenshot to help with your review. Ultimately, the prevention of these complications comes from a prevention of the myocardial infarction. The best way we can do that is with risk factor modification. This means helping people help themselves. The biggest risk factors for a myocardial infarction are smoking, hypertension, coronary artery disease, diabetes mellitus, age, and male sex. Some of these risk factors can't be changed, like age and sex. However, others can be modified. Cigarette smoking is the most preventable risk factor for an MI. If your patient has never smoked, encourage them to stay that way. If they are currently smoking, encourage and help them to quit. Hypertension, coronary artery disease, and diabetes may be improved with lifestyle modifications, like a less processed diet, regular exercise, and weight loss. If it's still uncontrolled, these diseases can also be managed with medication. And that's it. In summary, today we discussed the pathogenesis of myocardial infarctions, myocardial changes following MIs, possible complications of MIs, and risk factors for MIs. Let us know what you think. As always, be sure to like, comment, and subscribe. Also, follow our Instagram @MedisinStyle for more content. My name is Alyssa, and this is Medisin, where learning is always in style.